Welcome to the dilemmas of glaucoma. So today, in our daily glaucoma practice, usually we are meeting so much confusing scenarios. So this instructional course is mainly designed to help you to deal those confusing conditions. So I assure you that at the end of this course, you all will be able to deal those situations which are dealt in our course. Welcome you all.
Good morning, ladies and gentlemen. And our first speaker is Dr. Jaini, who shall be speaking on the disc dilemmas. And Dr. Jaini is a consultant at Amala Eye Hospital and an alumni of Thrissur Medical College. Over to Dr. Jaini.
Okay, so it is actually an easier situation when the intraocular pressure is raised. It is easier to diagnose glaucoma, but the disc dilemmas mainly arise when there are the optic disc and the visual field changes, but still the IOP is normal. We are confused whether is this a glaucoma patient or not. So the examiner has to rely on the appearance of the optic disc mainly to assess the glaucoma and diagnosis and the progression. So why is the optic disc evaluation very important? Because the optic disc and the RNFL changes is the first which occur and the visual field usually occurs later. The intraocular pressure and the visual field lacks the diagnostic sensitivity and 20% of the non-glaucomatous discs are treated as glaucoma. So we should be aware of the typical glaucomatous features and the non-glaucomatous features. So is this disc glaucomatous? If I ask you the question at this point of time, still we are again in a confused state. So we'll come to this question at the end of the session. So what are the typical glaucomatous disc changes? We'll just go through the typical changes. So main thing is that we should look the disc size. The size is usually, you should correlate the size of the cup with the disc. And regarding the cup, we should be noting the shape of the cup and the size of the cup, which is correlated to the disc size, and the thinning of the neuroretinal rim, notching, vascular changes, and the hemorrhages on the disc. As I told you, usually glaucoma is overdiagnosed in larger disc, and the smaller discs are actually more susceptible to glaucoma, which is usually missed. So the disc size should be always measured, and the cup should be related with the disc. And as I told you, how to identify the cup margins is very important because it's usually normally the cup is horizontally oval. So you should see where the vessel is bending. So here we can see this is the area of the vessel bending there, which gives us the limits and the margins of the cup. And the cup asymmetry between the two eyes, if it's more than 0.2, is more suggestive of glaucoma. Then comes the neuroretinal rim. As I told you, it's the thinnest neuroretinal rim should be identified. And the extent of the lost NRR, particularly the color and the focal notching, is very important in interpreting glaucomatous disc. Then comes the vascular changes. I told you the bending of the vessel is very important because it helps us in the contour cupping. You should find out the cup by the contour change of the blood vessels rather than the color cupping. Then the presence of disc hemorrhage is usually suggestive of glaucomatous progression of glaucoma and is more commonly associated with normal tension glaucoma. And the peripapillary changes, the beta zone atrophy, more suggestive of progression of glaucoma, and the typical RNFL defects which occur in the superior and the inferior area of the disc, which is more seen in a red-free setting. So these are the routine glaucomatous typical changes of glaucoma. So what is the disc mimickers and why are those mimicking glaucoma? The main thing is that either the cup disc ratio is very more or there will be a cup asymmetry will be there usually, and whether it's cup or whether it's pallor, we are still again confused. And the same hemorrhages, RNFL defects, visual field defects, all can be seen also in other conditions which may mimic glaucoma. So it's very important to differentiate each condition. So what are our optic disc mimickers? We have few congenital conditions which mimic glaucoma and few acquired conditions. We'll go into each condition. First, the congenital disc mimickers. One is the primary macro disc. This is the megalopapillae. Usually the disc is usually very big, usually bilateral from birth, asymptomatic. There's no any functional loss. The cup will be very big within an IC32 rule, dilated. So these are actually primary macro discs, which are not glaucomatous. Then this condition, optic disc coloboma, usually if we properly examining the disc, even though the pallor mimics some cupping and all, actually the excavation is seen inside the disc more inferiorly. And it can be associated with this retinal choroidal colobomas, and associated visual field defects, very dense defects, can be seen also in optic disc colobomas. Then the morning glory syndrome with more typical features, a unilateral middle-aged female comes with a particular appearance like this, where the disc lies within the excavation and the blood vessels are emanating from the central tuft, glial tuft, which can mimic similar visual field defects. And the optic disc pit, when we visualize the disc very clearly, we can see there's a small depression usually in the inferior inferotemporal area of the disc, which can be associated with serous macular detachment. Another particular condition is a superior segmental optic nerve hypoplasia, where we'll see only the superior disc pallor will be there with corresponding an inferior arcuate defect. Is usually associated with uncontrolled gestational diabetes babies born with GDM or with low birth weight babies. And the most confusing condition is the myopic disc. It's always confusing due to the shallow, large cups, tilted disc, oblique entry, and Dr. Jason will be enlightening this in the next session. So what are these are the congenital conditions, and what are the acquired conditions which are mimicking glaucoma? The most common mimicking conditions are traumatic causes, demyelinating causes, ischemic optic neuropathies, toxic causes, and the compressive optic neuropathy, which can mimic glaucoma. So why is this mimicking? Mainly it's due to we think it's something pallor or some cupping and all, but actually what is the most prominent feature in these conditions? It's mainly the pallor. This pallor which is more than cupping. When we examine the disc, we will see that the cup is very shallow and the pallor is more prominent. So we should not miss these conditions. Can be traumatic and toxic compressive lesions. The other important feature to differentiate it is that the age of the patient is usually a young patient, and the presence with early visual loss with RAPD, color vision problems, and the visual field defects will follow the vertical meridian. And usually these conditions, even though mostly are unilateral, it can be bilateral in case of hereditary cases and nutritional cases. And the RNFL thinning, mainly it is seen in the temporal RNFL thinning, which is more prominent in non-glaucomatous condition than the typical superior and inferior thinning in glaucomatous patients. So those points are important to differentiate both. So the retinal nerve fiber defects also is similarly seen in the ischemic causes, toxic, demyelinating causes also. We'll see the retinal nerve fiber layer defects which can mimic glaucoma. The retinal conditions also can mimic glaucoma. Due to this, the vascular occlusion is a very, even the glaucoma is a risk factor vascular occlusion. We should see the peripapillary retina for any perivascular sheathing, sclerosed vessels, new vessels, focal attenuation, RP degenerations to rule out this glaucoma. Neuro-ophthalmological conditions, as we already discussed, the chiasmal and the pre-chiasmal tumors can mimic glaucoma, but the pallor will be more than cupping, and there comes the importance of our Greenfield criteria, while we assess the age, visual acuity, RAPD, and the vertical field defects. Inflammatory conditions, even though in acute stage, it will not confuse us, but later when the patient comes with temporal pallor, it may confuse as glaucoma, but the subnormal color vision, visual acuity problems, and the central scotoma will help us to differentiate those conditions. Hereditary cases also can present with bilateral temporal pallor centrocecal scotomas, but the family history of poor vision, associated diabetes mellitus, sequential loss in Leber's hereditary optic neuropathy and all will help us find out the differentiation, and then in those cases there will be the temporal loss of RFL will be more prominent. So the take-home message is optometrics evaluation is the heart of glaucoma management, but still we cannot depend on the disc fully, and the entire clinical picture should be taken into the consideration. So this patient now, is this glaucomatous? Here it is a middle-aged female, large disc, large cup, normal visual acuity, visual fields are normal, and now it is not glaucoma. Thank you for your patient listening.
Thank you, Dr. Jaini. That presentation was very good and you helped us to elucidate a lot of dilemmas regarding the disc. I now request Dr. Jayashree to speak about glaucoma and myopia and describe her diagnostic ladder. Dr. Jayashree is presently working as a consultant in glaucoma at the iVision Eye Hospital, Thrissur, formerly with the Narayana Netralaya, and she is an alumnus of Thrissur Medical College. Welcome, Dr. Jayashree.
Good morning. At the outset, okay, it's good afternoon. Good afternoon. At the outset, I would like to thank KSOS and Dr. Jaini for the opportunity. The presentation is on glaucoma in myopia, and both the topics, both the diseases are a very difficult disease. Especially when it combined together, it's going to be a very difficult decision to make. But let's see what are the challenges that you face. But first, about the prevalence. By the end of the decade, you expect around 80 million people to suffer from glaucoma. And what about myopia? By 2050, around 50% of the population are bound to be myopic. And what about high myopia? That is patients having more than -6 diopter and axial length more than 26.5 millimeter is going to be 10% of the population. And when the time travels to 2050, this is how the globe will look like. Southeast Asia, around 65% or 60% of people will be myopic. So coming to India, what you see, 5 to 15 years, 7.5% of the kids are already myopic, more so in the urban population. By 2050, 50% of the population here are going to be myopic, and many of them glaucoma also. So glaucoma is, myopia is associated with so many other diseases. Glaucoma is one of the main problems. So many population studies have shown that glaucoma is associated with moderate to high myopia. And coming to the type of glaucoma that is associated with myopia, primary open angle glaucoma, normal tension glaucoma, and we should not also forget the pigment dispersion glaucoma, especially the young males with moderate myopia who comes with spontaneous fluctuation of IOP during exercises, and high IOP initially without field loss, who presents to us with these Krukenberg spindles, the highly pigmented, the coffee brown pigmentation in the open angles of the wide open angles. They have Sandermeyer's lines in the posterior lens, and they can, the ISOCT picture where you see deep anterior chamber, the concave iris insertion, and this is called the reverse pupillary block, where the iris hugs over to the anterior aspect of the lens. This is one condition where PI helps. The patient at presentation can have this bad visual fields. Here the OCT, what I am trying to highlight is the poor quality of the signal strength. This is not because of the technical error, this is because of the myopia itself. We'll come to that later. The challenges that we face when the myopia is complicating glaucoma is not just in the medical diagnostics, it's also in treatment of the patient. Coming to every aspect of glaucoma diagnostics is given a challenge by myopia. Coming to IOP, which is basic for glaucoma diagnostics, the scleral thinning, poor elasticity of the walls of sclera. These patients are vulnerable because of the scleral tension across the optic nerve head and lamina cribrosa. The lower axial lengths are more prone for IOP related problems. When the axial length increases, the IOP independent risk factors also gives a more challenge. Younger myopes are known to have higher daytime IOP, higher nocturnal supine IOP elevation, greater IOP fluctuation after exercises. And what about the post-refractive status of the patient? Most of the patients nowadays with myopia have undergone a refractive surgery. You have to ask the history of a refractive surgery and look for corneal thickness. And this is not sufficient. You have to look for the elasticity, hysteresis of the patient. And what about the IOP status? If the IOP is more than 20 millimeter of mercury, And if the axial length is 25.5, that itself is a risk factor for glaucoma. And when they act together, they are not simply additive, they are also synergistic. So that means these together can increase your risk for glaucoma by 16 times. And this is a patient who was put on all the medications possible, and she has presented with allergic eye disease, and the patient had probably a normal myopic disc and a normal visual fields, and the point I wanted to highlight here was the patient had LASIK and the corneal thickness was very low. Coming to optic disc, all these problems of scleral thickening, axial length elongation, everything is there, and with this you have to see the optic disc. You can see n number of variations of optic disc presentation. To find out your normal CDR, your normal ISNT and all is not going to happen in an optic disc when you have myopia. What all presentation can be there? Larger disc, tilted disc, shallow cup, nasal insertion, peripapillary changes of all forms, the gamma atrophy, beta atrophy, everything can be there. ISNT is never followed. You cannot see an RNFL defect because you have a severely tessellated background, and optic disc area increases with the refractive error of the patient. It is very difficult to judge. You have to have a high index of suspicion. All myopics, you have to look for glaucoma. It has to be a dilated 90-day examination. You have to have detailed serial stereophotography. Compare every time. Progression always favors glaucoma. Look for disc hemorrhages. If there is a disc hemorrhages, highly likely that the patient have glaucomatous damage. Coming to OCT, does the imaging help you? The normative database does not go beneath minus 12 diopter. So you don't have data beneath minus 12. What happens to highly myopic eyes? You don't have the good RNFL characteristics. They are flagged off. Poor image quality is a problem. Dissimilar database is a problem. And the average RNFL thickness itself reduces. 7 micron reduction happens for each 1 millimeter increase in axial length. For 1 diopter increase, minus 3 microns reduces. You have heard about red diseases. When you have no disease, but the imaging system diagnoses it as a disease. That is red disease. No disease, but the system says it's disease. And high myopes are more tend to have this problem because of the imaging issues. Segmentation errors. When the system algorithm measures the thickness and the target retinal layers, the thickness is measured, and if a problem happens in measuring of the thickness of the layers, as in high myopia, tilting of the disc, peripapillary atrophy, myelinated nerve fibers, then again the errors happens and the red areas are highlighted. Here again there is no disease, but that is how could I see that there is no disease? Because especially in the right eye, every area is red here, but the HFA is normal. What problem else do you see here? There is displacement of RNFL peaks. You can see that there are good peaks here, but it is displaced temporally. So displacement of temporal, that elongation happens, and temporal displacement of the RNFL peak happens. In hyperop, it comes together, nasally displaced. And this nasal temporal displacement leads to inferior red disease. Macular OCT is another promising tool because it is less affected by elongation of the globe, and it is more reproducible. And GCC with the temporal raphe, that horizontal demarcation where you lose GCC and it is horizontally demarcated, it is called temporal raphe. If you see a temporal raphe, it is highly possible that it is a glaucomatous eye. What happens in visual fields? Myopia have threshold sensitivity which is low, and there are defects that favor myopia and defects that favor glaucoma. And enlarged blind spot is a defect that favors myopia. So even if you have a normal, there are certain proportion of myopic patients who can be misdiagnosed as having glaucoma, and they might end up taking unnecessary treatment. So this 10% have glaucoma-like defects in spite having a normal myopic disc. So you should always be open to have, if the patient is not progressing, be open to change the diagnosis of glaucoma from that patient. You should be open to reducing the medication. So what about this eye? You can see that the right eye has enlarged blind spot. Between the eyes, the disc does not look very dissimilar, but the left eye definitely has a superior defect. But then I will rather closely follow up the patient. Maybe I'll put the medication for the patient in the left eye, but I'll rather closely follow up the patient. If the patient is not progressing, I'll rather safely observe the patient close observation. Progression favors glaucoma. Field defects continue to progress in spite of good IOP control because of the possible fluctuations. Glaucoma, myopia itself is a risk factor. Migraine, sleep apnea, anemia, hypotension all adds to the risk factor. Just a word about surgery. Hypotony is a major risk factor. So it's a tight balance between hypertony and hypotony. Mix is a promising surgery because the flap is not involved. I'll just take a minute on the take-home messages. There is a strong link established between myopia and glaucoma. Myopia is a mimicker in all parameters of glaucoma, so it poses challenge from IOP to imaging and visual fields. A high index of suspicion, a longitudinal follow-up, and looking for progression helps you diagnose glaucoma and myopia. Important when you plan surgery is remembering hypotony. So if you don't have your techniques correct, you are bound to fall from this ladder. Thank you for your patient listening.
Thank you, Jayasri, for that great, wonderful presentation. I invite Dr. Anup, sir, for enlightening regarding the phacoemulsification in shallow AC. What all things we should look for. He's a senior phaco surgeon at the iVision Hospital, Thrissur. He will be enlightening us regarding the same.
Very good afternoon. So I'll be talking on phacoemulsification shallow anterior chamber, and I'd like to thank Janie for having me in the team. Things to ponder. Actually, many times in this situation, there is hardly any time to ponder. You have to really go in and do some fast thinking. So pre-operative challenges, of course, many of these patients have small eyes. So IL power calculation is itself a challenge. So you cannot use the normal SRKT type of formulas. You may have to use like Holiday 2 or many of the ones which are available online, like the Kane formula. Then you have to keep the IOL ready because your normal inventory, you may not have powers like plus 30, 34 or beyond that. And most of the companies make only up to 34 diopters. So beyond that, you may have to think of piggyback IOLs. There is a possibility of the intraocular pressure elevating during the surgery also. So all of these patients, invariably, I always start IV mannitol, unless there is any medical contraindication for that. In some cases, you may need to give a block also with a good massage. And one important point is we have to just dilate the patient just before you are doing the surgery. Like if you have a big list, it should not dilate the patient right in the morning and do it as the last case. Interop challenges, anyway, I'll be talking along with the videos while I show the videos. So this is a normal cataract with a shallow AC. So this patient was moving the eyes a lot, so I thought I would go in and do a subtenance block because you don't want to have handle two problems at the same time. Because while you are operating on a shallow AC and the patient looking all over the OT, it's not very inducive. So when you are injecting something in the AC, you find the subincisional iris jumping. So that itself is an indication that in this case, that the AC is quite shallow. And the rexis also is a problem. You cannot do a normal rexis like a shear. As you can see, I am doing the rip maneuver because the anterior capsule is convex. So there is a chance of this rexis escaping. And the biggest problem is when you try to insert the probe. As you can see, our aim is to protect the cornea. So we always try to go along the wound and then the iris gets aspirated or stuck into the phaco probe. The point is you have to use only irrigation while you are going in. And you have to sometimes need to use high density viscoelastic also over the subincisional iris. After that, of course, the surgery is quite uneventful. So this is again a typical case of angle closure, post-angle closure glaucoma cataract. You can see the iris atrophy. There were two large iridotomies also. So in this case, the problem is that one is, besides the shallow AC, one is that the pupil is going to be very rigid and it will not dilate beyond the particular point. And there might always be, you should look for any small subluxations, small to large subluxations, which is also possible in a post-angle closure glaucoma attack. So this is one of the cases which I had operated. A similar case I had put in a CTR also. So the rexis was slightly small. It was around 4 millimeter, and this is how the eye came after a couple of months. Totally capsular phimosis, and it was not cutting with YAG also. So I had to again go in and cut it with the vanas. Many of these eyes, they also have the problem of a deep socket, because like I told you, the eyes are small. So normally myopes, we find them will have prominent eyes, whereas those hypermetropes and all, they may have a deep set eyes. So there is additional problem of, you can see the fluid, it's all getting collected in the fornix, in the conjunctival sac, and that will reduce the visibility. Your depth perception gets hampered, because, and there is a chance that you can cause a posterior capsular end, because you may think you are away from the PC, but actually, in fact, you may be quite close to it. So that is one thing. Another thing is, of course, the IOL that I was telling you. So in this case, I had to use the plus 34 diopter, so which fortunately was available with the manufacturer, and so that lens could be placed. But anything beyond that, of course, you will need to put a piggyback lens. This is one case which really stretched my patience. So it was like a hard cataract, and while doing the hydrodissection, the nucleus normally lifts. No, after that the eye became hard. What we call as intraoperative hard eye. You can see the iris coming out through the main wound. The wound was quite okay, but still the iris keeps coming out. That is because of the rise in the intraocular pressure. So trying to replace back the iris, again you have to keep checking the intraocular pressure with the dome of your cannula. Always better to reposit from the side port with a cyclodialysis spatula. And then once more trying to get in the phaco probe, but even before I could start doing it, the iris comes in. In this case, I had already given IV mannitol, so one cannot repeat it again. Burping out some of the visco, because sometimes overfilling also can lead to a hard eye. Again it keeps coming. Then this is when I inject some amount of viscoat over the subincisional iris, trying to make some space. And now I am finally able to get in the probe, but then still the iris keeps coming and coming into the port of the phaco probe. I tried to disentangle it with my chopper, but then I thought it's better to come out now. And then that's when I thought I should do a vitreous tap here. So you mark the pars plana 4 millimeter, then with a 26 gauge needle, I go in and just aspirate 0.01 to 0.02 ml. That much is sufficient, and you have to immediately close it with a bud. And then after that, you can see the AC is formed very well, and the rest of the surgery goes in. After that, the surgery is quite smooth. Sometimes they do say that you should not do a tap, that there is a possibility that you may have vitreous incarceration. But what I have seen is that if you have to go in with a vitrectomy probe, you need at least 23 to 25 gauge. Many of the time, those sort of small gauge vitrectors are not available with the routine phaco machines. So the ones which are available are either 21 gauge, and when you try to push in such a large vitrector through a pars plana, you may end up causing more damage. So I always prefer to do a vitreous tap with a needle. But what is important is that at the end of the surgery or the next day, you have to do an indirect ophthalmoscopy. And after 2 weeks, a regular indirect ophthalmoscopy with scleral depression. So at the end of the surgery, though we have struggled so much, only the little bit of iris stretching which is there in the subincisional area, otherwise it looks okay. Then another scenario where you get shallow AC or hypomature intumescent cataracts. So here the challenge is doing the capsular excess, because the lens is, as we know, is quite intumescent. So I am using a dispersive viscoelastic to flatten the anterior capsule, and stained also. But there is some fibrous plaques also on the anterior capsule. So those areas excess is difficult. So you have to go around those plaques, while including the plaques within the area of the removed capsule. And still in one area, the rexus is still attached. So you just trimmed that part also. And then after that, you can, once you have decompressed the lens, you have removed all the liquid cortical matter. After that, you can safely enlarge while using a microforceps. After this, the surgery is not that much difficult because it's like a regular white cataract. So it will go off as, then the end of the surgery again, and the other side also, because the rexes are small, I had to enlarge once more. Then some cases, I think you should be prudent not to do phaco, because you cannot do phaco in all cases. So this case, preoperatively, it's a hypermature intumescent cataract again, but I thought that the AC was slightly irregular temporally. So because of that, I went in, I did a scleral tunnel. So after staining, when I was washing the trypan blue, I saw a blob of vitreous in the wound. So there was a subluxation temporarily. So I did a vitrectomy initial, because already vitreous is there. So did some vitrectomy, clearing whatever vitreous has come into the anterior chamber. And then I thought it's better not to go with the rexes and then go do a phaco. That will be like too much of manipulations and risk. So I thought I'll go in, enlarge the tunnel, and I thought I did a intracapsular cataract extraction. So this is something we used to do initially during my PG days. I have done with a cryoprobe. So this is something like that. So what is important is that you don't rupture the bag at this point, because if the bag is ruptures, all that fluid cortical matter will go into the vitreous, and it can cause severe inflammation post-op. So managed to remove it intact, and vitreous is obviously there, so some amount of vitrectomy. Another thing I want to highlight here is that one should not use irrigation while removing the nucleus. So I am going in with and putting a iris claw lens, as we just saw in the previous session. And this iris claw, the advantage is you can put it in any axis. It need not be horizontal like the other lenses. You can put vertical, oblique. So this particular forceps is the one which is available and quite, because it has got that particular shape, flat edges. So it's useful to hold the lens. So you get a good result at the end of it. So thank you. I have tried to cover some of the scenarios where you normally get a shallow anterior chamber. Thank you.
Thank you, sir, for that great talk, because it is actually a very difficult situation where to do a phacoemulsification in very shallow. So as sir told, with a well plan, we can also do a phaco properly in a patient with a shallow AC. Thank you, sir. Next talk will be by Dr. Smita ma'am, my own mentor. She's working as the professor in Government Medical College, Thrissur, and she will be speaking about the topic IOP is normal, whether my patient is progressing or not. Because usually we see so many patients in our OPD, we see the IOP is always normal, but still the patient is seen progressing. So we'll see what Madam has have to tell us. Welcome to you, Madam.
Thank you, Dr. Jaini. Good afternoon, ladies and gentlemen. The dilemma is, the IOP is normal. Is my patient progressing? So this brings forth three questions in my mind. Does my patient really have normal tension glaucoma? Has the IOP been recorded correctly? And if the patient has normal tension glaucoma and the IOP has been recorded correctly, is the patient progressing? So let us come to the first question. Does my patient really have normal tension glaucoma? I shall be presenting a few case scenarios and we will discuss about them. So this is a 45 years old female with no family history of glaucoma. Her best corrected visual acuity is 6.6 and 6.9 with IOP of 16 and 17 with central corneal thickness of 534 and 539. There is a 0.5 cup in the right eye and 0.7 cup in the left eye. And the fields satisfy 1 Anderson's criterion each. So is this normal tension glaucoma? I did a gonioscopy in a semi-dark room with a 1 to 2 millimeter beam not falling on the pupil, and I found that this corneal wedge lies behind the iris. So this is actually a patient of angle closure glaucoma, and therefore performing a gonioscopy is very important to rule out the normal tension glaucoma as well as a primary angle closure glaucoma. Now, this is another patient, a 28 years old female with no family history of glaucoma. Vision is 6/6 in both eyes, and her IOP is 18 in both eyes. Central corneal thickness is normal. So this time a gonioscopy has been performed and the angles are found to be open. She has a 0.7 cup in the right eye with a corresponding inferior arcuate scotoma and a 0.6 cup in the left eye with a nasal step. So is this normal tension glaucoma? So upon close questioning, this lady revealed that she uses a fairness cream, and we know that any cream which contains steroids when used in the periocular region is very likely to cause raised intraocular pressure. So this cream contains mometasone furoate, and therefore it is very likely to cause, so this is a patient of steroid-induced glaucoma. This is the office diurnal of a third patient, and you can notice that most of the values are within the normal intraocular pressure range. So is this normal tension glaucoma? So we know that a significant percentage of people have raised intraocular pressure early morning before they wake up. So performing a 24-hour facing or diurnal test is important, and it is also important that we record the 24-hour blood pressure to rule out hypotension, nocturnal hypotension, and also systemic hypertension, which are important correlates with normal tension glaucoma. And finally, I have another patient who is a 34 years old female who has the same amount of cupping of 0.8 in both eyes. Intraocular pressures are 17. She has normal fields, but OCT in the left eye shows pre-perimetric changes, as you can see. And actually, it shows pre-perimetric changes in both eyes. So is this normal tension glaucoma? So when central corneal thickness was measured in this patient, it was found that she has very thin cornea, and this makes us falsely complacent, thinking that the intraocular pressure is normal. So these are some of the very common scenarios where we can confuse normal tension glaucoma with other entities. Most of the time, the etiology of normal tension glaucoma is thought to be vascular dysregulation. Therefore, a meticulous history taking of the patient and also with the spouse of the patient is important. With the patient, we should ask about the history of migraine with visual aura. We should also ask about the history of shock, or if the patient had to be hospitalized and needed a large blood transfusion, or any surgery where again there was a need for large blood transfusion, and if the patient performs yoga where the head is below the heart. We know that not only the Shirshasana, but there are plenty of other asanas which if held for sufficient amount of time can cause this kind of situation which is conducive for normal tension glaucoma. With the spouse, we can ask about history of cold, clammy hands, which indicates Raynaud's phenomena. We can ask about obstructive sleep apnea, which is shown by the snoring pattern of sleeping. There is another very interesting theory which is about the translamina cribrosa pressure differential. Most of you would be familiar with that, but I just want to reiterate that in a normal optic disc, there is a very delicate balance between the normal intraocular pressure and the cerebrospinal fluid pressure. This pressure differential in the glaucoma patient, where the intraocular pressure is high and the cerebrospinal fluid pressure is normal, causes the cupping of the optic disc. On the other hand, when the cerebrospinal fluid pressure is high with a normal intraocular pressure, it causes a mushrooming of the optic disc, and that's because of the translamina cribrosa pressure differential. In a patient with normal tension glaucoma, where the intraocular pressure is normal, and if the CSF pressure is low, it can cause a differential causing the cupping of the optic disc. So the Central India eye study has shown that middle-aged, tall, thin females can present with cupping of the optic disc. These people have a very low body mass index and they have normal tension glaucoma. These are like tall, thin, low body mass index, low waist circumference, that kind of people. So again, Dr. Jaini has talked very beautifully about neuroimaging, the need for neurological conditions to be ruled out, and I'm not going to describe them in detail. Again, multiple anatomical conditions which have been described before. This is an optic disc pit which can mimic glaucoma with a normal intraocular pressure. As far as to know whether the intraocular pressure has been recorded correctly or not, well, we have to perform a good applanation tonometry. This portion I'm not going to describe. Let us describe about whether the patient is progressing despite a normal intraocular pressure. Now, all of you would be familiar with this graph, which shows the changes in the visual field, in the optic disc cupping, and in the RNFL thickness with time. So, this is actually demonstrating the structure and function correlation with glaucoma with respect to time. As far as structural progression is concerned, we can detect structural progression with the OCT RNFL, which is most commonly used. This is the picture of the OCT RNFL which we use commonly. However, we can also take an OCT of the optic disc and an OCT of the macula, which can tell us about the RNFL thickness at the macula and also the GCIPL and GCC thickness. A short-term average circumpapillary RNFL change of 4 to 5 micrometer or a sector change of 7 to 8 micrometers is suspicious of glaucoma, especially when the age-related thinning is only 0.2 to 0.5 micrometer per year. So when we are taking an OCT to follow up a patient for progression, it is important that we should be aware about the artifacts. This is a study done by one of my postgraduate students, Dr. Gopika, who showed that there are multiple artifacts, especially the important six are the poor signal strength, decentration, abnormalities straddling the measuring ring, segmentation errors, and the green and red disease. As far as functional progression is concerned, visual fields and then the event-based and trend-based analysis are important in assessing the functional progression. Again, in normal tension glaucoma, an excellent study was conducted by one of my PGs, Dr. Devi Karthia, who showed that there is a definite neurocognitive decline, and this in patients with normal tension glaucoma. And this was shown by using the Montreal Cognition Assessment Questionnaire. So it becomes very difficult to consider the fields for normal tension glaucoma progression. In mild glaucoma, there is not only there is a pre-perimetric glaucoma, which is what we commonly hear, there is also a perimetric progression, which was endorsed by the World Glaucoma Association. So here we have to look for progression in green, meaning that all the sectors would appear green, and so we have to look at the actual values of the RNFL and then follow it up. An inter-eye difference of more than 9 micrometer is statistically significant for glaucoma, and we can combine it with the GCIPL measurement at macula to make a decision. Functional progression in mild glaucoma can be from new enlarging and persistently deepening defects. Moderate glaucoma, we can use event and trend-based analysis, but in early moderate glaucoma, the neuroretinal rim thickness has to become significantly lesser before a visual field change is detected. And then there is a tipping point, which is actually 1/3 of the normal thickness, when the visual field changes become very apparent and which rapidly progresses. So this is called the broken stick model of asymmetric progression of moderate glaucoma. In advanced glaucoma, there is floor effect, and so OCT RNFL is not useful. So we can use the GCIPL as Dr. Jayashree has described in her myopia descriptions. Fields, we can use the 10-2, we can use the size 5 target, we can use the macular progression, and finally we can also use the kinetic perimetry. And finally, I want to tell you about a beautiful study done by one of my then PG, Dr. Neetu Pradeep, who said that in advanced glaucoma, patients are simply not good at evaluating their own functional ability. Therefore, patients with disease of the same nature may have more variation when they are asked to tell about their performance through a questionnaire. So finally, I conclude by saying that structural testing, functional testing, and IOP measurement are important in assessing the progression of glaucoma, especially when the intraocular pressure is normal. But the clinical experience of the treating ophthalmologist and each patient's specific clinical context is important before we make a decision about progression. Thank you very much for your kind attention.
Thank you, Smita ma'am, for enlightening us that there are many other aspects while treating a normal tension glaucoma patient. Thank you, ma'am. Now we would like to entertain the questions from the audience.
I have a question for Dr. Anup. You were mentioning about various scenarios of shallow anterior chamber and doing phacoemulsification. With respect to glaucoma, we encounter a lot of patients who have had an acute attack of angle closure glaucoma who do not come in time, which has become chronic, and the intraocular pressure doesn't come down, even if we are giving mannitol. So, do you do anything special in such patients to take the lens out? Because most of the times they have cataract. It's not that we only do a trabeculectomy. Most of the times we do a trabeculectomy, and that itself is very difficult. Do you do anything special, especially since the anterior chamber is shallow? And would you please give a mic to sir? Anterior chamber is shallow, endothelial cell count is low. Do you do anything special?
No, in this case, probably you would have done a trap, is it not? Like a case with a...
Most of the time, the patients present with very high IOP. So mostly not for cataract surgery. We would be doing a trab initially first.
Yeah.
Again, trab would be very difficult because the AC would be very shallow.
Okay.
Do you do anything special, or in a patient with nanophthalmos? That was my second question, actually.
Yeah.
Do
The
you
same
do
thing which I was...
sclerotomies? Do you do any sclerotomies?
No. I've not done sclerotomy, even in anophthalmos cases. But I have in such cases, generally, I mean, after giving mannitol and maybe even iris, the vitreous tap which I showed, that was the only thing which I have done. I have not done a sclerotomy per se. But I could able to manage just with the tap, many of these cases. Yeah.
Shallowing of the anterior chamber has to be prevented in all these instances.
Yeah.
So we'll just go for just a single case discussion. We have some more time. We will also entertain more questions from the audience. This is just a case scenario. Actually, it's a 52-year-old female hypertensive patient, a valvular heart disease patient. And her visual acuity was 6/6 with an appellation photometry of 14-16 both eyes, and the GODO showed open angles with a central corneal thickness of 524 and 528. And this was actually her fundus finding. Ma'am, would you like to comment on this, Smita ma'am?
This patient shows large cups. Probably the disc on the right side is larger. Probably there is an RNFL defect in the inferior part in the left eye.
Okay, ma'am. And the visual fields actually, the finding showed like in the right eye there was a nasal defect, a dense defect, and the left eye there was an evolving superior arcuate defect actually. And the OCT, again ma'am, these were the findings actually, which usually correlated with the findings which we saw. Is an inferior RNFL thinning there. So in this time of point, actually, what will be our plan of management, madam? The IOP is within normal range because we have already gone through the discussion.
So here we have a patient who has a normal intraocular pressure measurement, perhaps measured once or perhaps measured twice. I would go for a facing, and that patient is showing an RNFL defect. So we are considering this patient having a glaucoma because the perimetry as well as the OCT is showing glaucomatous changes. So we have to rule out all those vascular, the history should be very meticulous. We have to rule out all the conditions that I mentioned before, like Raynaud's phenomena or obstructive sleep apnea or shock or yoga postures or whatever. So to rule out all these things. And then we have to measure the intraocular pressure along with the systemic blood pressure at multiple times, a Holter monitoring for 24 hours or 24-hour diurnal facing. Those are important to know whether this is a primary open angle glaucoma or a normal tension glaucoma. The angles are open, is it?
Yes, ma'am.
Yeah, and the central corneal thickness measurements. These are the common things which I would like to rule out.
So, madam, how to the proper facing? How can we, whether we'll do the office hours, how can we will miss the peaks and all the early morning peaks?
I work at a medical college, and so therefore we have a lot of PGs who are there to help us out. But I don't think mostly people can go for 24-hour facing. But office diurnal at least is very important, even though that does not rule out primary open angle glaucoma.
Okay, thank you. Anybody from the audience would like to add on, or is there any questions?
Since this patient also has a valvular heart disease, I would like to add a carotid Doppler for this patient.
Okay, thank you for the information. We'll go to there's a question for the audience actually. What is your indication for a Rho kinase inhibitor? Is it to decrease the corneal edema post cataract surgery, or will you use it as a first line anti-glaucoma drug, or as a second line or an add-on drug, or none of the above? How much of the audience will poll for the first option? You can just Dr. Anoop is there. Second option? Nobody is there. Third option? So that's for the majority. So even though there are many new studies describing that they can be used as a first line drug, usually this is followed thing is that either it's used as an add-on drug, or we can use it, usually it's also used after cataract surgery to decrease the corneal edema. Okay, I'll show, again I'll project one more case to Dr. Jayasri. He's a 33-year-old male actually, and his visual acuities are within normal limits. Appellation tonometry is on the higher side, 27-25. The central corneal thickness is 660 in the right eye and 672 in the left eye. Anterior segment within normal limits, gonio open. And this was actually the fundus appearance. Dr. Jayasri would like to comment on this. Visual fields are normal. And the OCT was showing superior RNFL thinning.
So the question is whether do you want to treat
or not? What will be our plan of management?
So the IOP has to be taken in consideration with the corneal thickness. Corneal thickness is like way high, 670 and
yes,
all. No?
Yes.
So as such, we don't directly use a formula to take the value of your IOP, but you know that with a mental calculation, this is way high and your IOP is not like very high. But it is still in the borderline. Even though if you correct with the calculations, it is still in the borderline. And what I understand is like the visual fields is okay, and imaging does not show very definite glaucoma like changes. But in the visual fields, what I would like to see again is the 24-2C or the 10-2. Because in an HFA, to say it is normal, especially in an ocular hypertension scenario, if 10-2 is involved, it is glaucoma itself. And here the RNFL, you have to see the GCC also. Earlier involvement can happen in GCC. So if GCC is involved or 10-2 is involved, it can again be glaucoma. Again, if the IOP is borderline also, if you have a family history, if the patient is not able to follow up, if the patient has other comorbidities, definitely the indication is towards treatment rather than observation.
Okay. So that will be the plan. If your patient IOP is normal or the IOP is in the higher side with a raised CCT, you should also see for the other risk factors like if presence of family history and whether the patient is progressing or not to determine the plan of management. So thank you for your active participation. Thank you, Dr. Smita, Dr. Jayasri, and Dr. Anup sir, for enlightening us. Thank you.